disorder that can occur following breast cancer procedures that remove the tissue in the upper outer quadrant of the breast and or axilla, causing long-term disabilities interfering with sleep, performance of daily activities, including use of the affected arm, leading to frozen shoulder or complex regional pain syndrome. So the evolution. This pain syndrome was first reported by Wood in 1978. Foley and colleagues described a discrete set of symptoms in 1980s. However, in the last several decades, there have been a wide discrepancy in the reported prevalence of chronic neuropathic pain. 20 to 68% of women are affected, although many cases are underreported. This condition can develop up to several months after surgery and can persist for 3 to 6 years. PMPS is caused by the direct nerve injury, example severance, compression, ischemia, stretching and retraction during the breast cancer operation or from the subsequent formation of traumatic neuroma or scar tissue. It is typically located in the upper arm, underarm, shoulder and the chest wall, areas served by the damaged cutaneous branches of the intercostal nerves of T4, T5 value and intercostal brachial nerve and in the surgical scar. It is described as a burning sensation, shooting or throbbing in nature. Symptoms might also include abnormal sensations such as electric shock type of pain that overlies a constant aching and burning feeling, being aggravated by shoulder strain, household work or even simple stretching. The risk factors being the tumor located in the upper outer quarter of the breast and the extent of the axillary intervention, treatment with radiation or chemotherapy post-surgery, younger age group considering the aggressiveness of the surgery of the tumor and the larger tumor size. The management is a multidisciplinary treatment approach consisting of non-steroidal anti-inflammatory drugs, antidepressants and nerve blocks, injections with local anesthetics and steroids to the pain limited to the surgical scar, that is 2 ml injections of equal ratio of 0.5% of bupivacaine and 4 mg per ml of dexamethasone. So Dr. Laura S.R. told the ASCO Post that she found the maximal point of tenderness usually at the 6 o'clock or 9 o'clock position along the inframammary fold. What she did is she used the mixture of bupivacaine and dexamethasone and inject this at the site of the neuroma where the T4 and T5 nerves likely exit the chest wall. She waited for half a minute and then massaged it in. Within a minute, the patient has no more pain. For 60% of the patients, she never had to inject again. Other modalities being the ketamine infusion reduce the acute postoperative pain, morphine consumption, and the development of PMPS without any serious side effects. Non-pharmacological measures being the massage therapy, acupuncture, reflexology, and counseling, physical therapy with arm and shoulder exercises. So, considering the huge prevalence of PMPS, we have started following up the breast cancer patients after surgery who complained of pain from 6 months to 2 years to find out the incidence of PMPS in our center. This helped in the establishment of therapeutic guidelines to minimize the pain and limitations it causes. Thus, I conclude, although recent advances in diagnostic and surgical procedures have reduced the frequency of the more invasive surgical procedures, there is still a considerable risk of developing PMPS after treatment of breast cancer. Thus, this necessitates the development of more effective prevention and treatment strategies for this syndrome to improve the patient's quality of life. Finally, I would like to thank you, my mentor, Dr. Jyotsna Goswami, for her support and guidance and for encouraging me to present in this international conference. Thank you.
Thank you, Dr. Momita. So, what are your comments, please?
Momita, actually I was expecting you to present your own data, and I really don't have any questions. Thank you very much. Spoke well.
That's for me also.
I just request people not to go out when the presentation is going on because it causes a lot of disturbance. So, in between when we are talking that time, if it is possible to go out or so. invite Dr. Shamor Haldar. Let's just invite our next speaker, Dr. Syed. Dr. Syed is again from NFI Medical College, Bangalore. We have already seen a very fantastic study being done in the hospital, so accepting for a few more studies as well. Over to you, Dr.
Good morning. I'm Dr. Syed Fazal from NFI Medical College. I'm here to present a similar study. You've seen my friend presenting it. This is a study on anesthesiologists. This is a survey on attitude and knowledge towards chronic pain among anesthesiologists in Bangalore city of South India. So to introduce, pain is one of the most commonest symptoms encountered with doctors on a day-to-day basis. It is also a very important issue regarding its complexity and its effects on quality of life. Inadequate treatment of chronic pain is still a serious problem despite widespread availability of effective medications and treatment modalities. Numerous barriers have been identified that prevent doctors from providing effective treatment for pain, including their knowledge and attitudes. Management of pain has always been a challenge for anesthesiologists. Over past few decades, working perimeter of anesthesiologists has greatly expanded from operating rooms to intensive care units and pain management clinics. The aim of this study was to survey the knowledge and attitudes regarding chronic pain management with a questionnaire among anesthesiologists in Bangalore city of South India. Bangalore city has 7 medical colleges and is a hub for providing health care. The concept of chronic pain among anesthesiologists in this city is still new and is upcoming. Hence, this study was taken up in this city of South India to evaluate the knowledge and attitudes towards chronic pain in anesthesiologists, among anesthesiologists. The methodology that was adopted, first of all, the ethical committee clearance was obtained, and this study was conducted in the month of June and July 2015. All the practicing anesthesiologists from Bangalore who volunteered to take part in the study were given a set of questionnaire, and 15 minutes were given to each volunteer to complete the questionnaire. The methodology was similar to that of my friends. It contained 15 multiple choice questions. The questionnaire was actually designed, the questionnaire which you saw with my friend, it was actually designed for the anesthesiologists, and later on as a continuation study it was just used in interns. And the volunteer was asked to mark the correct answer. That's what and all the anesthesiologists were asked to give the details, and then the 15 questions 1 to 5 was to evaluate the attitude, and the remaining 10 questions, the question number 6 to 15, was to assess the knowledge of the anesthesiologist. Again the same, the chi-square test and one-way ANOVA was used for statistical analysis. The total of 86 anesthesiologists from Bangalore, which included senior residents, assistant professors, associate professors and professors practicing in Bangalore, took part in the study. All the participants were in the age group of 29 to 63 years with an average of 32.93 with a standard deviation of 8.63 years. And in the study, 75.59% were males and the remaining were females. The attitude of the anesthesiologists toward chronic pain, here the 55.8% of the anesthesiologists answered the questions correctly with a mean of 2.79 with a standard deviation of 1.169. And similarly, the knowledge of the anesthesiologist towards chronic pain, 48% of the anesthesiologists answered the questions correctly with mean of 4.8 with standard deviation of 1.827. This is a bar graph which shows the attitude, the mean attitude to 2.79 and the mean knowledge 4.8. This is the question wise. The question number 3 was answered like 90% of the people, 90% of the anesthesiologists answered this, the question number 3 correctly, and question number 8 is the second. So the question number 2 was the, like, only 27% of the anesthesiologists would answer it correctly. The statistical analysis were divided. For the ease of the statistical analysis, the groups, the anesthesiologists were again divided into 3 groups. One is the anesthesiologists having experience of 1 to 10 years. The group B was the anesthesiologists having experience of 11 to 20 years, and group C was anesthesiologists all having more than 21 years of experience. So with this bar chart, it's very clear that the number of correct answers given by the experienced anesthesiologist is more. To discuss the difficulties in treating patients with pain are compounded not just by lack of knowledge but also by behavior that is guarded by their attitude. Hence, the importance was given to evaluate both knowledge as well as attitude of the anesthesiologist regarding chronic pain. Questionnaire was designed in this study was a self-design, keeping in mind the basic attitude problems that are faced during chronic pain management, and the knowledge was also the questionnaire for the knowledge was also designed keeping in mind the basic knowledge that is required to treat a patient with chronic pain. A total of 86 anesthesiologists took part in the study, where only one anesthesiologist managed to answer all the 15 questions correctly. Of the 5 questions framed to evaluate, the anesthesiologist, the mean percentage of correct answer was only 55.8%, which was not satisfactory. The 10 questions that were framed to evaluate the knowledge of the anesthesiologist, the mean percentage of the correct answer was 48%, which suggests that the knowledge regarding chronic pain management is inadequate. To conclude, knowledge and attitudes of anesthesiologists in the Bangalore towards the chronic pain is not satisfactory. Pain medicine being an upcoming and essential field needs efforts to remove the barriers and with respect to attitudes and knowledge of the anesthesiologists. Programs like conferences, continuing medical education programs, pain symposiums and workshops dedicated to pain management are needed to improve the knowledge regarding chronic pain. This was my questionnaire, that's similar to my friend. These are my references.
Amongst the 3 groups, so what was the result of that?
The result of that was the anesthesiologist with higher experience answered the questions correctly, answered more questions, like
Was it
the
statistically
percentage.
significant?
Not that significant. Yeah,
Right.
it was an observational study. Yeah, it was not that.
No.
Yeah.
Was the difference between the groups statistically significant?
No, it was not.
It wasn't. So, the other thing is that, can you give me one example of a question which actually looks at the attitude? If you go back to the questionnaire, and then which one is the question which tests the attitude?
The question number 1 to 5.
1 to 5.
Which of the following is associated with chronic pain? As depression,
How
anxiety?
does this test the attitude?
It's just the approach towards the patient. How?
I don't think it correctly measures the attitude towards pain, because this is again testing the knowledge. Can you go to the question which measures the knowledge?
So neuropathic pain can result in which of the following conditions, such as central sensitization, allodynia, hyperalgesia, all of these. And the next question is like, what is the upper limit for the morphine that is treated?
Okay, thank you.
How many of the anesthesiologists were in pain clinic there, whom you have included in your study? Any of them were was running a pain clinic?
Yes, ma'am. 2 people.
2 people.
Only 2.
So they will have more knowledge and attitude towards chronic pain.
Yes, ma'am.
Is it not so? Then why? Then how you can compare? In which group they were there? They were in which group?
Well,
Those
this was
anesthesiologists.
just to evaluate general knowledge of anesthesiologists.
But
not
the
to compare.
anesthesiologists who are running pain clinic, they must have more knowledge than others. Is it not so?
Yes, ma'am.
Don't you think so?
Yes, ma'am.
they will have more knowledge, more attitude also will be, their attitude also will be positive.
Yeah.
So they should be excluded from your study. Is it not so?
Yes, ma'am.
You are saying.
Thank you, Dr. Syed. Dr. Shamor Haldar. Pal? Yours has been loaded, sir? Okay, fine. Sure. You are from? Okay, Dr. Atish Pal is from Apollo Hospital, Delhi. Over to you, sir. You stay off. Yeah, you're staying. Yes.
Okay, a very good afternoon and warm greetings to the judges and my fellow colleagues. I am Dr. Atish from Indraprasth Apollo Hospital, New Delhi, and I will be presenting my case, which is a comparative evaluation of the intra-articular bupivacaine versus bupivacaine with dexmedetomidine as an adjunct for post-operative analgesia in arthroscopic knee surgeries. Nowadays, arthroscopy is one of the most commonly performed orthopedic procedures, and it's a minimally invasive surgical technique, and it is being used for both diagnosis and repair of joints also. Since it is a minimally invasive surgery, it decreases the risk of complications and the recovery time. But studies have shown that there is moderate to severe pain, which in turn affects the patient's activity level and his satisfaction also. Various modalities and techniques have been used for the analgesia for knee surgeries, and at present the multimodal analgesia is the preferred norm. The various techniques which have been used are the opioids, local anesthesia, which consists of the regional blocks, NSAIDs, along with intra-articular drug instillation. In spite of all these techniques, there is no preferred technique or any gold standard technique. And so we propose to assess and compare the post-operative analgesic effects of intra-articular dexmedetomidine administered as an adjuvant with local anesthetic bupivacaine in patients undergoing arthroscopic knee surgery. During the course of the study, we assessed the patients for the duration of analgesia. Pain scores were assessed using the VAS scores. Sedation scores were noted, and the need of rescue analgesics was also noted. Dexmedetomidine was first approved by the US FDA in 1999 and has since been used, but its usage has mostly been limited to the sedation part. But in the very recent past, its usage has spilled over to anesthesia and analgesia also. It is a potent and highly selective alpha-2 agonist. It has a good safety profile, and it provides fair hemodynamic stability. It has been shown to reduce the requirements of opioids, propofol, and benzodiazepines also. So after the Institutional Ethical Committee approval and prior written informed consent, we started the study, and it was a randomized, double-blind, controlled, and prospective study over a period of 1 year from January 2013 to August 2014, and systemic sampling method was employed for selection of desired number of patients. Patients coming for elective unilateral arthroscopic knee surgeries under general anesthesia between the age group of 18 to 65 years, of either gender, and belonging to ASA class 1 and 2 were included in the study. And patients who refused to be a part of the study had hypersensitivity or allergy to the study drugs, had impaired renal or hepatic function, pregnant patients, and patients on chronic pain medications were excluded from our study. So 60 patients were incorporated into the study and were divided into 2 groups of 30 patients each. Both the groups received a total volume of 20 ml of intra-articular solution. The 2 groups were the group Dexmed, which is our study group, and this group received 0.5% bupivacaine along with 100 microgram of dexmedetomidine, while the group saline, which is our control group, received 0.5% bupivacaine along with 1 ml of isotonic saline. The study was double-blinded as both the performing anesthesiologist and the orthopedic surgeon administering the drug were blinded to the study. So after thorough prior pre-anesthetic checkup, all the patients were given routine general anesthesia consisting of fentanyl, propofol, and atracurium, and were maintained on oxygen, nitrous, and isoflurane. For surgeries which were expected to last more than 1 hour, IV fentanyl in the dose of 1 microgram per kg was given 45 minutes after receiving the first dose of fentanyl. So towards the end of the arthroscopic procedure, the orthopedic surgeon injected the intraarticular solution into the knee joint through the arthroscopic cannula sheath after withdrawal of the camera, and this was followed by wound closure, and subsequently the tourniquet was deflated. The surgery was concluded with reversal of the residual neuromuscular paralysis, and LMA was removed. The patients were then shifted to the post-anesthesia care unit and were assessed at 30 minutes, 1 hour, 2 hours, 4, 10, 18, and 24 hours. We assessed the patients for the total amount of analgesics received, the time of the first analgesic requirement. The pain assessment was done using the visual analog scale, and vital parameters along with postoperative nausea and vomiting and sedation scoring was also done. The patients who complained of pain scores more than 3 were given rescue analgesia with tramadol, which was our first rescue analgesic, and if the pain did not subside on tramadol, they were given diclofenac sodium, which was our second rescue analgesic. After conclusion of the study, statistical analysis was done using the SPSS program for Windows version 17. Unpaired t-test, Mann-Whitney U-test, chi-square test, and Fisher's exact test were used, and p-values less than 0.05 was taken as a significant difference. The two groups were comparable on the basis of gender distribution, age distribution, and the type of surgery. 3 types of surgery were taken into account: diagnostic arthroscopies, ACL repairs, and meniscectomies. This graph shows the comparison of the VAS scores between the two groups. The white line shows the control group, while the blue line shows the study group. And we observed that the patients in the control group complained of more VAS scores during the first 2 hours, while in the later stages, after 4 hours, the two groups were comparable on the basis of VAS scores. This graph shows the comparison of the sedation scores between the two groups. And we noticed that there was no statistically significant difference between the two groups on the basis of sedation scores. This bar diagram shows the comparison of tramadol usage, which was our first rescue analgesic, at different time intervals. And as we noticed with the pain scores, the patients in the control group required more tramadol during the first 2 hours, while after 4 hours, the tramadol usage in both the groups were not statistically significant. This bar diagram shows the comparison of the diclofenac usage, which was our second rescue analgesic, and there was no significant difference between the two groups on the basis of diclofenac usage. This chart shows the comparison of the time for the first top-up, and the patients were, we noticed that in the saline group, which is our control group,